I've had the privilege of working with our jaundice management devices, and I'm delighted to be able to share my knowledge and experience with you all today. So, without further ado, I will continue with today's presentation. Now, assessing jaundice in the newborn infant is really a very important factor. And so the learning objectives that we will cover today are that by the end of this session, we will be able to describe the mechanisms for hyperbilirubinemia. We will be able to discuss the risk factors and the process of Kernicturus. We'll be able to assess and evaluate infants for risk of jaundice. We'll discuss the American Academy of Pediatrics guidelines for hyperbilirubinemia and identifying infants at risk. And we'll describe the clinical role of nomograms and phototherapy and their application to our clinical practice. So let's look at the basic facts. Well, really there's quite a renewed interest in jaundice and hyperbilirubinemia in the newborn infant. And elevated bilirubin levels we know can be toxic to the infant's central nervous system, but the difficulty is that we don't know exactly at what level this happens, so the primary purpose for treating hyperbilirubinemia with phototherapy especially is to avoid the development of Kernicturus, which is a condition we know with devastating long-term neurological sequelae. Now each year approximately 60 to 70% of the 4 million newborns born in the United States will become clinically jaundiced. We know that a normal newborn produces between 6 and 10 milligrams per kilo milligrams per deciliter per day of bilirubin, or for those of us working in micromoles, anything between 100 and 170 micromoles. And this is almost twice the load produced by an adult, and partly due to the shortened lifespan of the infant's red blood cells and the increased stiffness of the red blood cell membrane, which hemolyzes more readily as the cells pass through the circulatory system. And the infant's higher hemoglobin and higher hematocrit levels also present an increased load of bilirubin as their red blood cells break down. Now we know that normal physiological processes mean that bilirubin will generally peak on the 3rd to the 5th day of life, and usually it's a benign condition, it's self-limiting, it usually resolves on its own by the 1st week of life, and usually it will require no treatment. However, what we need to remember is that it is a very common diagnosis in the newborn population, and out of those 60% of term babies who develop hyperbilirubinemia, approximately 8 to 10% of those will require treatment. Now, we also know that there is a much higher incidence in preterm babies, and approximately 80% of all preterm babies, again, will develop hyperbilirubinemia, and almost all preterm babies will require treatment. We know that jaundice is the #1 cause of hospital readmission for babies. It's the #1 reason that babies are brought back to the hospital within the first few days of life. And the suggestions that with today's practice of delayed cord clamping, that maybe the incidence of jaundice and hyperbilirubinemia is actually rising. Let's think a little bit about our bilirubin production. So bilirubin basically is derived initially from red blood cells, and as our red blood cells break down, they break down into the byproducts where we get globin, heme and iron. And the byproduct from the heme is this molecule called bilirubin. Now in this format, this bilirubin molecule is fat-soluble, it's unconjugated, and it binds to our albumin molecules. It gets transported through the hepatocytes, where it becomes conjugated through a number of processes, and then it's excreted through the bile, through the urine, and through the feces. So, like we've said, unconjugated bilirubin is fat-soluble, and it is transported in the baby's circulation tightly bound to albumin. So jaundice, as we describe it, is the yellow discoloration that results from the hemolysis of the red blood cells. As these red blood cells split, they become heme, which partly degrades to bilirubin, and the globin, which is reutilized to form new red blood cells. So babies can appear icterate when bilirubin levels are greater than 6 to 7 milligrams per deciliter, or sort of 100 to 120 micromoles. Now, we know that unconjugated bilirubin can move into the tissue, like we've mentioned, and this is what we see as jaundice. But the important thing to remember is that unconjugated bilirubin can also cross the blood-brain barrier and cause neuronal injury. Now, we think about albumin binding. When we focus on the treatment of indirect jaundice and its relationship to Kernicterus, it's the cycle in the sort of center portion of the previous slide where we focus our attention. So that's the metabolic pathway to where the sequence of events occurs. And we know that in its unconjugated form, bilirubin combines with albumin, which is one of the plasma proteins we have in our blood. And bilirubin that is not bound is referred to as free bilirubin. Now, when we talk about albumin, there are two very important terms to remember. The first term is capacity, and that describes the number of binding sites that are available on the albumin molecule for bilirubin to bind to. And the second term that we talk about is affinity. Affinity is the tightness with which the bilirubin is bound to the available sites. What we need to remember is that other substances can also compete for binding sites. So, for instance, hypothermia and acidosis may also interfere with albumin binding, and free fatty acids may compete for sites such as those we find in lipid solutions. We also know that hypothermia may increase free fatty acid production. So an infant who's been subjected to hypothermia may also have more free fatty acids which are competing on this albumin molecule for binding sites with bilirubin, and hence may be more at risk for hyperbilirubinemia. So in order for our body to get rid of indirect bilirubin, it must be bound to albumin, it must be transported to the liver, and there it must be metabolized. So once the bilirubin is in the liver, it's conjugated by the enzyme UDP-GT, and also for this conjugation process, the baby will require glucose and oxygen. Also something very important to remember in babies with persistent hypoglycemia or hypoxia. The good thing is that if this works well, this conjugated bilirubin, this direct bilirubin, is water-soluble, it's non-toxic, and then it's excreted from the body in the feces and in the urine, and so the baby is able to eliminate it. So, as we said, once conjugated in the liver, the bilirubin is released into the bile duct, it's delivered to the intestinal system, it's eliminated in the stool and the urine in normal circumstances. However, this conjugated bilirubin may be relatively unstable. Even if conjugation of the molecule takes place, enterohepatic circulation is enhanced in the newborn. And this refers to the conversion of urobilinogen, which is the most common form of the conjugated molecule, back to that indirect or unconjugated bilirubin by the enzyme beta-glucuronidase. This reconverted, this conjugated to unconjugated molecule, can then be absorbed across the intestinal mucosa, and it can re-enter the circulatory system. And then it has to be represented to the liver again for conjugation for a second time. The other thing that's very important to remember is that intestinal motility can be relatively slow in the newborn infant, particularly those babies who may not be feeding so well. And this encourages reabsorption to become enhanced. So this is a very important thing to remember, that we must encourage good feeding practices to encourage this intestinal motility and prevent delayed passage of meconium and delayed stooling in infants. So let's have a think about how does it become elevated, this bilirubin. Well, it's very simple. It's either increased production, that means the baby is making too much, or it's decreased elimination, which means the baby is not excreting it fast enough, or it's a combination of the both. So it's the baby's making too much bilirubin and they are not eliminating it fast enough. And I like to use the analogy of a sink and a tap and the waste outlet moving out from that tap. So imagine you turn the taps on in your sink in your kitchen or bathroom and you turn them on at a normal flow rate. The basin of the sink will partly fill with water, but if the outlet is clear, it drains away quite quickly. If you turn the taps on very, very quickly, the sink may overflow. Or if you have a blockage in your outlet, again, the sink may overflow. And this is very similar to the kind of bilirubin process within the body. You either make too much or you can't excrete it fast enough. So I'm going to open a poll question for you. This is everybody's chance to actually answer a question and make sure that we consolidate our learning. So if you use your computers, you can vote on the question. So bilirubin, is it transported to the liver? Is it bound by red blood cells, by white blood cells, by albumin, or by plasma? And I can see that quite a lot of you have voted. I'm going to close the poll in just a couple of seconds and we'll take a look at the results. And yes, I can show you the answers in just a moment. Most people have answered correctly. Bilirubin is transported to the liver bound by the albumin molecule. So this is very important when we think about how that bilirubin is moving through the body, thinking about other things that are actually competing for albumin binding sites. The red blood cells are what break down to create this bilirubin. So the correct answer there is in fact albumin C. So well done to those of you who answered that correctly. So moving on, let's have a little think about the risk factors for hyperbilirubinemia, and this is in full-term infants. So if you have any of these things, you are at risk for hyperbilirubinemia. So certainly jaundice within the first 24 hours of birth. This is not normal, and you are certainly at risk of developing quite significant jaundice. If you have a sibling who was jaundiced as a neonate, you are more likely to be jaundiced. If you have unrecognized hemolysis or even recognized hemolysis, so whether you have an ABO incompatibility or a rhesus factor incompatibility between baby and mother, this is a risk factor for hyperbilirubinemia. Non-optimal sucking or nursing. Babies who are not feeding well are not encouraging gastric motility, and therefore there may be the increased risk of reuptake. Babies who have a deficiency in G6PD, they are at risk for hyperbilirubinemia. This is something that we routinely test babies for. Any baby with sepsis or infection, any babies with Keffel hematomas or bruising, they've already had an exacerbation of breakdown of red blood cells, and any baby of Eastern Asian or Mediterranean descent also. These babies are also a much higher risk factor for developing hyperbilirubinemia. So let's have a think about how this process works. So we talk about the term jaundice, and this is where this unconjugated bilirubin is depositing in the skin and the mucous membranes, and it's causing this jaundice, this icterus in the newborn infant. When we start to see the unconjugated bilirubin depositing in the brain, this is where we start to see signs of what we call acute bilirubin encephalopathy. And the term Kernicturus actually relates to the permanent neuronal damage that has been caused by these deposits of unconjugated bilirubin in the baby's brain. So just to describe acute bilirubin encephalopathy for you. So acute bilirubin encephalopathy, or ABE as it's sometimes known, is the clinical manifestation of bilirubin toxicity in the early neonatal period. And there is a clear progression of symptoms that are important to understand because Kernicturus can be prevented if aggressive treatment is initiated in the intermediate period. By the time advanced symptoms of acute bilirubin encephalopathy are seen, then usually the central nervous system damage is irreversible. So we can assess the progression of ABE by thinking about when it starts and what signs and symptoms we see. So first of all, the early manifestations. This is babies with severe jaundice. They may be lethargic. They may be hypotonic. They may have a poor suck. This is the early signs of acute bilirubin encephalopathy. The intermediate stage, and if I just say to you that there is anecdotal evidence that suggests that if we catch these babies at this point, that we exchange transfusion, there is a potential to reverse the central nervous system changes. But these are the babies who present with a moderate stupor, they're irritable, they can be hypertonic, they get this backward arching of their neck, the retrocollis, or the backward arching of the trunk, which is the opisthetonus. They can have a fever, a high-pitched cry, or alternatively they can be have this hypertonia which alternates with drowsiness and hypotonia. So they never have normal tone. They're either hypertonic or hypotonic and become drowsy in between. And then finally the advanced stage, and certainly after the first week of life, the central nervous system damage is most likely irreversible at this point. And this is where we see this very pronounced retrocollis opisthetonus, this real backward arching. These babies have a very shrill cry if they are not already in a coma. They don't feed, they become apneic. Like I said, they have a deep stupor to coma status sometimes, again a fever. These babies have seizures, often subclinical seizures. And these is a group of babies it's very interesting to apply AEEG monitoring to determine if there is actually any seizure activity. And obviously in worst case scenario, these babies actually die. So let's have a little think about Kernicturus a bit more. Well, historically, Kernicturus was really first described back at the turn of the last century, and Schmall in 1904 described this yellow staining of the basal ganglia in the brain of infants who died with severe jaundice, and he called it Kernicturus. And this was also noted further back by Orth in 1875. Now we know that extreme hyperbilirubinemia causes bilirubin encephalopathy and causes toxicity to the hippocampus, to the brainstem nuclei, the cerebellum, to the basal ganglia. These are all areas of the brain that become damaged. Now, bilirubin levels at which Kernicturus occurs may vary dependent on the presence of hemolytic disease and dependent on the infant's gestational age. And in fact, there's really no safe levels of bilirubin have really ever been identified. It's difficult to say there is a cutoff level, and at this level, no infant will ever suffer Kernicturus. So it is rare, but it is a preventable cause of severe morbidity in otherwise normal infants. And therefore, for me, this is what I believe can be deemed a public health dilemma. This is something that is completely preventable with appropriate policies and guidelines in place. No infant should ever, ever suffer from Kernicturus, and therefore I think we can deem it a public health dilemma when we see infants who are actually suffering from the condition. So who is actually at risk Well, certainly the full-term babies, and this is when it's associated with severe hyperbilirubinemia for whatever cause, whether that's hemolytic disease, sepsis, obstruction, whatever the cause is, full-term babies are definitely at risk. The same with preterm babies, and in preterm babies we know that this may occur at lower bilirubin levels. We know the risk factors for Kernicterus are the peak bilirubin level, the highest point it reaches, the duration of the hyperbilirubinemia, and also the bilirubin to albumin ratio. So if the albumin ratio is low to bilirubin, then this is also a severe risk factor. And we've talked about some of the signs and symptoms. So the early signs we talked about with acute bilirubin encephalopathy, but the late signs, particularly of Kernicterus, are athetoid cerebral palsy, auditory dysfunction, dental enamel dysplasia, paralysis of the upward gaze, and less frequently intellectual handicap and other handicaps. And this is the very sad part here, that these infants or these children as they grow up are usually intellectually normal, and they are trapped inside bodies that simply don't work. So a little bit more, this is a very good study that was published by Denery as far back as 2001. And again, they looked at the pathophysiology of Kernicterus. And they mentioned that physiological hyperbilirubinemia, the increased bilirubin production, the decreased bilirubin conjugation and decreased excretion were all risk factors and part of the pathophysiology. And they determined that pathological hyperbilirubinemia would be a bilirubin level of greater than 17 milligrams per deciliter. They also looked at the factors affecting neurotoxicity, and they looked at the concentration of the bilirubin in the brain. They looked at the duration of exposure to bilirubin, and what they actually found was that the correlation between serum bilirubin and neurotoxicity is weak, except in those infants with hemolysis. So we have to consider all of the risk factors in every baby when we're thinking who may be at risk of Kernicterus. So, is it a problem? Is Kernicterus actually a problem? Well, certainly it was a major problem in the 1950s to 1970s, and this is where rhesus hemolytic disease was common. Kernicterus had a very high incidence. But due to the invention of exchange transfusions, rhesus immunoglobulins with anti-D, and advances in phototherapy, there was a markedly reduced incidence of Kernicterus really by the 1980s. But then the 1990s started to see an increase in Kernicterus again, and this really stems the question why. Why would we have seen an increase in Kernicterus at this point? Why did the problem get worse? Well, there are several factors that may have contributed to the rise in the re-emergence of Kernicterus. And basically, at this point in time, changes in practice of discharge management of mothers and babies changed. Historically, it was normal practice that mothers stayed in hospital for sort of 5 to 7 days after birth, and hence there was a much greater clinical input during that peak phase of bilirubin production. So shorter hospital stays without early or adequate follow-up, remembering bilirubin peaks on between day 3 and 5 of life. Think about when most babies go home, and I can tell you in Europe it can be very common to certainly be home within 24 hours, certainly as early as 6 hours post-delivery if there are no complications. So, you know, babies were going home earlier, practice of discharge had changed, but jaundice management protocols didn't change at this time, and people were still scheduling 2-week follow-ups even for high-risk infants, which were leaving babies very vulnerable and at home during this peak risk phase of developing hyperbilirubinemia. Now, we know that Kernicterus really is a living nightmare, and for these families, they have this dream birth, and it really is followed by this living nightmare. And infants and children with Kernicterus, and for anybody who wants to learn more, please visit this website, pic.org. And this is for a website built by parents of infants with Kernicterus. And they say that those living with Kernicterus face many challenges. They badly need hope. When jaundice takes its toll, it can rob children of the ability to eat, to speak, to sit, to stand, to grasp a utensil, to hear, to see, all while their mental abilities are all intact. Like I said, they are trapped in bodies that don't work for them. And those living with Kernicterus have almost nothing in the way of treatment options. Medicines and therapies do little to help. There is no standard course of treatment. There is no cure. But what we do know is there is prevention, certainly prevention of Kernicterus. I'm just going to share with you one very short case study. This is baby boy B. It was a mother's first baby, born at 37 weeks gestation, being exclusively breastfed, was discharged with a total serum bilirubin of 15 milligrams per deciliter. And the family saw the pediatrician twice during the first week of life with concerns of excessive jaundice, with concerns of excessive sleepiness, and all were dismissed by the doctor simply because the baby was gaining weight. On day 9, this baby was difficult to wake and was having seizures. And when readmitted to the hospital, had a total serum bilirubin of 45.9 milligrams per deciliter. And this is baby boy B today, trapped in a body that doesn't work for him, simply because somebody chose to ignore the fact that his parents were concerned that he wasn't feeding well, that he was looking excessively jaundiced, and never checked his bilirubin level. Now, this is a very poignant quote from a mother of, again, a baby with Kernicterus, and she says that Kernicterus is a never event. It should never happen. It's like leaving a sponge inside a patient during surgery. It should never happen, yet it does. And she says that over 12 times I asked the doctors and nurses about his bruising, about his early birth, about his colour, and every single time they dismissed my concerns. And this was on the phone, this was face-to-face, and this was even in the emergency room when he lay dying in my arms. Again, this is a never event. This is 100% preventable, and this family lost their baby to hyperbilirubinemia and Kernicterus. So I'm going to open the next polling question for you, and if you'd all like to take a vote on the poll. So if you think about what we've just talked about, so Kernicterus, think what is the correct answer? It's preventable. It's caused by high levels of unconjugated bilirubin left untreated. It can occur in both term and preterm infants, or the answer is all of the above. So have a think about what we've just discussed. In a couple of seconds I will close the poll so that we can move on. I can see that most of you have actually voted. So I'm closing the poll. I can tell you everybody answered correctly. The answer is clearly all of the above. Kernicterus is 100% preventable. It is caused by high levels of unconjugated bilirubin left untreated. It can occur in both term and preterm infants, so all of the above is indeed the correct answer. So thank you for answering that question. Okay, so let's think about root cause analysis. Let's go through a 4-point patient care process and think about how we can prevent this. So we'll look at patient assessment, continuum of care, patient and family education, and finally treatment. So patient assessment, let's take that. Now, we know that the unreliability of visual assessment of jaundice in newborns, especially those with dark skin, is very high. It's very subjective. It's certainly not an objective test to determine hyperbilirubinemia. And failure to recognize jaundice or its severity based on visual assessment and measure a bilirubin level before the infant's discharge from the hospital or during a follow-up visit may mean that this is one of the root causes. We've missed appropriate patient assessment. Also, this involves failure to measure the bilirubin level in an infant who's jaundiced within the first 24 hours of life. Now, there are many ways that us as clinicians assess infants for jaundice, and we'll take a little look at all of them now and think about the pros and cons of them. So we just mentioned visual assessment, and this is sometimes a very commonly used method, yet it's not reliable and not specifically accurate. Certainly it dates back to the late 1960s, where a gentleman called Dr. Kramer and his team developed an assessment score process where, dependent on which part of the baby was displaying signs of jaundice, determined what the serum bilirubin level would be. But like I say, it can be very subjective, and particularly in darker-skinned infants, not reliable or accurate. We know that the gold standard test for bilirubin measurement is to measure the amount of bilirubin in the infant's serum. But this obviously involves blood sampling. This is the total serum bilirubin test. And blood sampling is in itself not without risk factors, and we know causes discomfort for the infants because we need to take blood from them. So more recently, transcutaneous bilirubin measurements have been shown to be reliable and to be accurate for screening infants for jaundice. And being non-invasive, these measurements are very simple to perform and can also facilitate follow-up for infants at home and in the clinic follow-up. And remember, it's always very important that we're plotting the infant's bilirubin levels according to the nomogram, and that we plot their bilirubin level in their postnatal age in hours. So please do make sure that all bilirubin levels are plotted accurately. And this may sound like a bit of a silly thing to tell you, but do remember when you're plotting bilirubin levels that you're plotting the level at the time or the age in hours at which the blood sample was taken, not the time at which the result was received back at the neonatal intensive care unit. So again, care needs to be taken to document the time or the age in hours in which bilirubin levels have actually been sampled. Let's take the second root cause, continuum of care. We've talked about this a little, and we mentioned about early discharge. So if we're discharging mothers and babies early, so before 48 hours, and we're not following them up within 1 or 2 days of discharge, and this is particularly important for infants of less than 38 weeks gestation, we may be again exacerbating the problem. It's part of the continuum of care root cause. Again, failure to provide early follow-up with physical assessment for infants who are mildly visibly jaundiced before discharge. And if we fail to provide ongoing lactation support to ensure adequacy of intake for breastfed newborns, this is a very important part of our continuum of care, that we make sure that these babies feed well, that mothers are supported well, and that we encourage this gastric motility. The third cause really is lack of patient and family education. So the failure of us as clinicians to provide appropriate information to parents about jaundice, and a failure to respond appropriately to parental concerns about a jaundiced newborn. So, you know, concerns about poor feeding, concerns about lactation difficulties, concerns about changes in newborn behaviour and activity. We really have to act and investigate any parental concern in jaundiced newborns. And then finally, let's think about treatment. The root cause when it comes to treatment. So failure to recognise, address or treat rapidly rising bilirubin is inevitably putting these infants at risk of Kernicturus. And the important thing is that we do aggressively treat severe hyperbilirubinemia in a timely manner with intensive phototherapy or exchange transfusion. And I will go on to describe the definition of intensive phototherapy for you. So we know the clinical role of phototherapy. Phototherapy is a standard of care for the treatment of neonatal hyperbilirubinemia. It's a widely accepted technology. It's widely used in the hospital and in the community setting. It's considered a relatively benign therapy, but it is, again, do remember, it's very important that we cover the eyes of the baby whilst under phototherapy in order to protect the retina. Now, there are several factors that affect the efficacy of phototherapy. So the first factor is the intensity or the brightness of the light. This is measured in units of microwatts per centimetre squared per nanometre. And it's important to remember that intensity varies inversely with distance from the patient, basically meaning the closer the light to the patient, the higher the intensity. The next factor that affects the efficacy of phototherapy is spectrum, or the wavelength, or the colour of the light. And this is the measurement that's taken, it's the units of nanometres. And we know that the peak bilirubin absorption occurs at 458 nanometres. And the third factor that affects the efficacy of phototherapy is the treatment surface area, the amount of surface area of the baby's body that's actually being treated. So very important to expose these babies completely to phototherapy lights, and even expose them top and underneath surface. So if the baby is lying prone, to consider lying them on a phototherapy blanket as well as shining light to them from the top surface. Now, we talked about this term intensive phototherapy, and the American Academy of Pediatrics from back in 2004 give guidance on the irradiance levels that should be applied for intensive phototherapy, and they state that intensive phototherapy implies the use of high levels of irradiance in the 430 to 490 nanometer band, usually at 30 microwatts per centimetre square per nanometer or higher. This is the definition of intensive phototherapy, 30 microwatts per centimetre square per nanometer or higher, and delivered to as much of the infant's surface area as possible. Now, let's have a little think about how phototherapy actually works. So clearly the light penetrates the skin surface. So exposed skin surfaces to phototherapy, the proper intensity of light aids in breaking down circulating bilirubin in the skin. And once it's broken down, the molecules can then enter the liver for conjugation and excretion processes to occur. So it's a very important process because phototherapy chemically changes the bilirubin molecule to its water-soluble form. But like we mentioned earlier, very important to remember that some of these new molecules can be changed back to their original form through the enterohepatic circulation. So there are two types of photochemical reactions that can take place, and they are photoisomerization and photooxidation. So photoisomerization is by far the most common, and two photoisomers are possible, photobilirubin or lumirubin. Now, lumirubin does not readily convert back to its original form, and it's therefore the preferred photo product, and it's thought to be the major pathway through which phototherapy works. Formation of this depends on the wavelength of the light and the intensity of the light source. Photooxidation is a much slower process. It's a much more minor contributor, but again, important to remember that it requires oxygen, and that babies who are hypoxic, this process may not occur so well. So I'm going to go to the next poll question. Let's see if you remembered what we addressed just 2 or 3 slides ago. So if I open the poll, Do you remember we talked about the level of intensive phototherapy? So intensive phototherapy implies the use of what light intensity? Is it 15 microwatts per centimetre squared or higher? Was it 22 microwatts centimetre squared per nanometre or higher? Was it 30 microwatts per centimetre squared per nanometre or higher? Or was it 50 microwatts per centimetre squared per nanometre or higher? And again, I can see that many of you have finished the poll. So I'm going to close the poll. Again, I can tell you that clearly everybody was paying attention, or that you know the fact already. The answer is C, that intensive phototherapy implies the use of a light intensity of 30 microwatts per centimetre squared per nanometre or higher. And for those of you who have your phototherapy lamps in your NICU, I would actively encourage you to take a radiometer, or to ask your biomedical engineers to take a radiometer and test that your lights are achieving this level of 30 microwatts per centimetre squared per nanometre or higher. So let's have a little look at system-based policies and procedures and things that we need to do. So when we think about our hospital nursing policy and procedures, it's very important that we are providing parental education materials, particularly on discharge of babies from the hospital. And that we do have a nursing policy and procedure in place where jaundice is evaluated by nurses, that it's a clinical vital sign, that we do check it periodically, and we think about testing with transcutaneous bilirubin. We use that as a screening tool, and we validate or corroborate this information with total serum bilirubin in infants that we're particularly worried about. We need to make sure we are assessing and promoting optimal lactational nutrition, that we're encouraging good feeding, that mothers are confident with their feeding, or that they have lactational support. It's important to make sure that we track and evaluate babies at risk of hemolysis, and that we follow infants who are on the bilirubin nomogram at the high or the intermediate risk, so greater than the 75th percentile track. We must follow these infants up. That it would be really good for all infants that we do a pre-discharge transcutaneous bilirubin, or if we're doing the metabolic screen, the blood tox spot test before these infants are discharged, then we actually check a total serum bilirubin whilst we're bleeding them. We need to make sure we do have a risk-based post-discharge bilirubin follow-ups. We need to assess each individual or each infant as an individual, and dependent on their risk factors, we need to schedule the appropriate follow-up for them. And we need to prospectively manage parental education, parental expectations, and inform parents of potential risks and things that they must watch out for in their infants. And for any baby where we see a total serum bilirubin of greater than 25 milligrams per deciliter, then we absolutely have peer review and further investigation on these babies. So let's have a think about a couple of scenarios. So let's take the baby who has early onset severe hyperbilirubinemia, and the baby who might have a total serum bilirubin of greater than the 75th percentile at less than 72 hours of age. So we need to do a very detailed clinical history. We need to check for hemolytic disorders. We need to do a clinical evaluation, checking for any signs of acute bilirubin encephalopathy. Some people may institute testing the bilirubin albumin ratio, so to check the level of serum albumin. We need to evaluate hemolysis, so we need to check the baby's blood type and do a Coombs test. We need to check for G6PD, etc. We need to observe the rate of rise of bilirubin. So are these babies jumping tracks on the nomogram? Are they rising their bilirubin levels very, very quickly? Any baby who fits this criteria really deserves an AABR hearing screen. These are the babies who are at risk of auditory neuropathy because of hyperbilirubinemia. So they really must have an AABR, automated auditory brainstem response hearing screen. And for these infants, we absolutely must employ intensive phototherapy. And, you know, potentially also it might lead to exchange transfusion if there is failure of intensive phototherapy. Now let's think about the infants with late onset hyperbilirubinemia. So this might be a total serum bilirubin, a high one of greater than 95th percentile, but it happens later in life. It happens at greater than 72 hours of age. So again, we need to consider the clinical history. We need to counsel the mum regarding feeding and stooling patterns. We need to find out from her how all of this has been going over the previous few days. The same clinical evaluation for the signs of acute bilirubin encephalopathy. We might want to, again, check the serum albumin, measure the bilirubin to albumin ratio. Again, we're going to evaluate them for hemolysis. Absolutely, again, we need to do an AABR hearing screen, particularly if they meet any of these criteria, that they have an abnormal bilirubin to albumin ratio, they have an abnormal clinical examination, and they have a total serum bilirubin of between 18 and 22 milligrams per deciliter. And again, these babies absolutely fit the criteria for intensive phototherapy and for exchange transfusion if the situation does not resolve in response to intensive phototherapy. So there may be something that we call the need for crash cart management of dangerous hyperbilirubinemia. So like we've mentioned, we will assess all babies for clinical signs of ABE and look at any jaundiced newborn with any neurological symptoms. We do an immediate transcutaneous measure of bilirubin and we send an immediate blood sample to the laboratory for a very fast response result. If the baby's symptomatic, we start intensive phototherapy, and also important to conduct our procedures whilst the baby's under the light. You know, don't switch the lights off for procedures, or at the very least keep a blanket or bed phototherapy light running at the intensive phototherapy irradiance of 30 microwatts per centimetre squared per nanometre or higher, and we need to admit these babies directly to the intensive care nursery. We may need to arrange for an expeditious exchange transfusion, particularly in those infants who have any signs of bilirubin encephalopathy, and perform it promptly. And so we need to think about all of these things in prevention. So this is a bilirubin care map to prevent this situation of acute bilirubin encephalopathy. So we can basically look at the nomogram and decide, are the babies in the low risk zone, are they in the intermediate zones, or are they in the high risk zone? And if they're in the low risk zone later on in age, in hours, then they'll just receive a clinical follow-up. They may get another transcutaneous bilirubin measurement within 48 hours at medical discretion. So this is the very, very low risk zone. Any baby who is jaundiced in the very early hours of life really needs to have continued checks for jaundice. Again, with transcutaneous bilirubin, it's fine as a screening tool, but at least every 8 to 12 hours. And for these babies who do fall in the high-risk zone, we need to do regular total serum bilirubin measurements, following them up really at least every 6 hours. And if they're at the very high level, then certainly we need to initiate this intensive phototherapy, particularly if they're having total serum bilirubin rises of greater than 0.2 milligrams per deciliter per hour. Now, I mentioned the American Academy of Pediatrics guidelines a little earlier. Now, the American Academy of Pediatrics issued some guidelines actually back in 2004 for the management of hyperbilirubinemia in the newborn infant of 35 weeks or more gestation. And just as we've mentioned in this presentation, they suggest that we absolutely should promote and support successful breastfeeding. We need to establish nursery protocols for the identification and evaluation of hyperbilirubinemia. We need to measure the TSB or the TCB on infants who are jaundiced in the first 24 hours. We need to recognize that visual estimation of the degree of jaundice can lead to errors, particularly in darkly pigmented infants, and that we need to interpret all bilirubin levels according to the infant's age in hours. And then moving on, they suggest we need to recognize that infants of less than 38 weeks gestation, particularly those who are breastfed, are at a higher risk of developing hyperbilirubinemia, and they do require closer surveillance and monitoring. We need to perform a systematic assessment on all infants before discharge for the risk of severe hyperbilirubinemia. We need to provide our parents with written and verbal information about newborn jaundice. We need to provide appropriate follow-up based on the time of discharge and the risk assessment findings, and we need to treat newborns when indicated with phototherapy or exchange transfusion. So I guess the question is, are you meeting the standard of care in your own facility? So think about it. Is jaundice routinely assessed and documented as a vital sign in my hospital? Are risk factors for jaundice routinely addressed and assessed? Do nurses and bedside caregivers have the ability to order a total serum bilirubin or transcutaneous bilirubin when visual jaundice is noted? And are the TSB and TCB results interpreted based on the infant's age in hours? Finally, is there a procedure in place to notify healthcare professionals of results? Are we definitely notifying people when we see infants who are falling within the high-risk zone, or are we simply just noting it down and filing it in the baby's notes? So, are you meeting the standard of care? Are infants discharged before 72 hours of age seen for follow-up within the next 2 days? And that follow-up is dependent on their bilirubin level and their risk factors. Is there an evidence-based protocol for treatment and follow-up in place? And does my hospital or community setting have the necessary therapeutic equipment available to provide intensive phototherapy and monitor progress? And finally, are parents educated about jaundice, beginning even in their prenatal classes, during their hospitalization, and do they go home with written materials upon discharge? So I would urge all of you, if you don't have one, to create your jaundice management protocol, to create a task force to involve pediatricians, neonatologists, nurses, practitioners, to review the available clinical evidence, to establish the goal of your protocol, identify the factors that will get you to your goal, and then write your protocol referencing current clinical evidence and best practice. And there are many sample jaundice management protocols that you can readily find available that you might want to refer to. So I'd like to ask my final poll question really before we close. So just interested, for those of you who are listening today, do you currently have a jaundice management and assessment policy? Are you developing currently a jaundice management and assessment policy, or do you not have such a policy at all available in your neonatal or pediatric environment? So again, I can see that Many people have nearly answered, so I'm going to close the poll just shortly now. Very interesting. It's very good to see, actually, most people do have a jaundice management and assessment policy, and there are several people developing one currently today. So this is really good news that hopefully we can be identifying these infants, and we can be 100% preventing this situation ever of babies developing Kernicterus. And again, I would urge all of you to ensure that your phototherapy lamps are checked and that they are tested and that they are definitely emitting the high levels of irradiance that we expect, and also to think about this procedure of exposing as much of the baby's body surface area as possible to lights, particularly in those infants with severe jaundice, and by using blanket or bed phototherapies in conjunction with overhead lights at the same time. So, in summary and to close, we know Kernicterus still occurs, but as we said, it is preventable, and prevention is important. So we need to evaluate the risk factors. Remember, we looked at the acronym Jaundice. We need to evaluate babies with transcutaneous bilirubin or total serum bilirubin and have a low threshold for repeating that, particularly in those babies who have risk factors. We need to ensure adequate feeding and intake to encourage this gastric motility, and especially important in the breastfed infants. We need to have early follow-up of infants, specifically those infants with risk factors, within 1 to 2 days after discharge, particularly if they're less than 48 hours of age. We need to give good information, education and instructions to parents to make sure that they know what to look for and who to call in the case that they see an infant with any problems. And we need to implement aggressive treatment, early intensive phototherapy for any baby presenting at the facility with signs of severe hyperbilirubinemia or bilirubin encephalopathy. And this really also stems the question of where these babies may be readmitted to, and if babies are readmitted through your emergency room system, I would urge you to ensure that the emergency room has intensive phototherapy available, even if it's a blanket or a bed phototherapy, to place that baby on immediately whilst they are waiting for the bilirubin results to come back from the laboratory. It's a benign therapy. It's not going to hurt the baby if we give them the therapy. What may harm the baby is if we do not give them the therapy whilst we're waiting for results. So hopefully I think we've covered our learning objectives today. I'd really like to thank you all for joining us on today's eSeminar. I would urge all of you to visit our Neonatal Care Academy at www.neonatalcareacademy.com, where you can find many more interesting courses and eSeminars to attend. So that's going to conclude today's recording of the session. What I'd like to do is ask any of you